Welcome. You, Hi, everyone. Welcome. You've come to a great GDermFresh episode because if you're like me, you you really need a freshen up in these areas, and we've got the perfect person to do it. So may I have the slides, please? Hi, Brooke. Hi, Eva. I see people getting on. Welcome, everyone. So you're on the GDermFresh, okay? You're on our Zoom. And basically, generational dermatology is all about looking to the future and preventing. It's all about prevention. We know what's happening to our patients, so we want to get ahead of it, not wait for it to happen, and practice generational dermatology. It's great. It's a great practice. It involves all generations. All these patients are in your offices, and it brings families together. I'll take the next slide. So you can join us for this. We're going to be live this year, and it's President's Day weekend, February 16th to the 19th. 2023. We do have early bird registration. We have an amazing faculty. And the thing about this meeting is that we cover everything. We cover, inflammatory diseases, cosmetics, oncology. We're going to be doing alternative medicine. We're going to be doing LGBT issues, different very new drugs, and also some good practice things, how to practice build, talking about radiation, new treatments in skin cancer, and really want to bring pearls to you. So this is a practical meeting, and you can be guaranteed you're going to walk away with really good pearls, really good practice tips, and things that can, of course, bring revenue into your practices, as well as give, high level patient care. So if you haven't registered for the meeting, please do. And we look forward to seeing everybody, especially you people from the East Coast in February. It's nice and warm here. And this is the property. It's lovely. It's beautiful. It's a Omni Resort. It's just a phenomenal property. Next slide. So now we'll get to the main event, which is our expert speaker. Dr. Nancy Anderson is here tonight, and she's a board certified dermatologist practicing at Loma Linda Medical Center in Loma Linda, California. She completed her dermatology residency at Henry Ford Hospital in Michigan. She is a generational dermatologist because her father was also a dermatologist. Dr. Anderson in 1988 co-founded the dermatology department at Loma Linda. She's a professor of medicine and has been section chair as well as a residency director, where she actively trains residents. Nancy, has there been a resident that's come through Loma Linda that you haven't trained? Oh, you're on mute. Nancy, I think you're muted.
Right, my apologies. There we go.
So my question was, has there been a resident that's come through Loma Linda that you haven't trained?
I trained every resident that has come through Loma Linda. I'm really blessed. I helped start the residency program years ago, and I'm seeing every resident come through. So it's been a blessing. I'm starting my 41st year at Loma Linda. Hard to believe.
Wow, and not looking it, let me tell you that.
Well, thanks to all the wonderful things you teach me, Wendy.
But yeah, so I mean, Nancy is a sought after expert in psoriasis and inflammatory diseases of the skin, and her expertise has brought her all over the country, all over the world, to talk about these diseases. So today she joins us on GDermFresh, and thank you, Dr. Anderson, so much for being here. And I will let you take it away.
All right, so we'll start. Thank you all so much. Thank you, Wendy, for the wonderful introduction, and thank you all for being here. And I think I have also been blessed to be with Wendy every for every one of her GFreshes now. So I'm so honored by that.
Thank
So I'm
you.
going to have our gentleman put on our Jack slides. So I am going to talk about psoriasis and eczema today because those are my go-tos. I just feel I've been so blessed to be in this area because it has changed dramatically. Just to give you a quick background, I trained at Henry Ford Hospital. And of course, when I trained, we had no biologics, we had no JAK inhibitors. We basically, for psoriasis, we admitted our really severe patients. We had a 20-bed unit for psoriasis patients. We used a tar and light and methotrexate, and eventually Soriatane came on board. But I had no biologics, I had no JAKs. So, you know, younger people are so blessed to have such a new array of wonderful treatments. And I'm always on a learning curve, and I want to teach you all so you'll have a better feel for them. I also want to mention I have been chief at the VA many years ago. They retired me out in 17 because after 32 years, they decided it was time I moved forward, but I wasn't ready to retire. So I am still at Loma Linda half-time. I'm actually the clerkship director, but I also help in the committee of picking our residents, and I oversee teaching our residents. At Loma Linda, we have 9 residents, 3 per year, so I'm very proud of them. I want to just thank Stacy Roddick, who helped me. She's applying for dermatology. She's a first-year internal medicine resident, but she did a phenomenal job of helping me with this at well. And I'm going to try to get her to come out, be able to be available to us, and maybe attend our spring. And I hope you all will come in the spring because it is, I agree with Wendy, it's a phenomenal location. Okay, next slide. And we don't need my disclosures, so I'll move on to the next slide. And I want to first talk about the deepening understanding we're trying to have of molecular processes and the immunologic proteins that are involved in the skin. And the JAK inhibitors are emerging as very viable and very effective treatments for multiple skin disease. You know, it's interesting that as I put the slide set together, actually one before I even was able to change the slide just got FDA approved like a week ago. So we're going to talk about all those. But there's multiple now being approved for not only topically, but also systemically. And so I'd like to discuss today the role and the influence of the JAK inhibitors and what they're having in our dermatology world. So next. So again, we're going to talk about the JAK signaling pathway to illustrate the mechanism by which they are actively will affect our and decrease our inflammatory factors. So we'll tell you basically how they're used. And also, I want to also talk about the clinical trials and the efficacy and safety of the various JAKs. And also, I want to talk about black box warnings. And I think that's what concerns us. You know, all the newer products, unfortunately, have started having a class effect. So I want you to be aware of that, but not frightened by those. And I hope I can teach you to be comfortable with using them, even with these black box warnings. And I want to also praise the use of available JAK inhibitors for the treatment of dermatologic conditions. So I'll move on to the next slide, please. And again, many of you know, give you a little background. JAK is an acronym for a Janus kinase. So this class includes a protein group of proteins, which include JAK1, JAK2, JAK3, and also the TYK2, we call them. And as you can see in this diagram, we also are going to talk about the STAT proteins, and that means STAT stands for signal transducer and activator of transcription proteins. So the STAT protein includes 1 through 6. So there's 6 different family subclasses of STATs. And one cytokine pathway can activate multiple JAKs. However, each cytokine pathway will activate only certain STATs. So basically you have your cytokine mediated receptor, the JAKs, and these are the tyrosinase residues. The JAK phosphorylase kinase residue, by the way, it's tyrosine kinase, I'm sorry, residue by the activation of the 2 JAK proteins. So what you're doing, the JAKs are activated by a cytokine that dimerizes. So this is basically occurs at the combination of the receptor, the JAK inhibitor. Their recruited STAT proteins dock to the tyrosine residues, and this catalyzes their phosphorylation. So they have inactive STATs that can trigger this. The activated STAT proteins then form new dimers, and these dimers enter the nucleus of the cells, and therefore they bind to target genes, as you can see here. So STAT binding sequences in the promoter to cause transcription to new genes that are responsive to cytokines. And the next slide. And then you can see that each JAK protein then has a subtle different ATP binding docket. So those dockets are where we're going to use it for specific diseases. So I hope I'm not overwhelming you, because this is a whole new form of mechanism of action, but I hope I've simplified it so you may understand. But they bind, the JAK inhibitors, or what we call JAK inhibs by some people, bind to the ATP binding site of the protein. So this suppresses its enzyme activity, and therefore it ends up suppressing that cytokine signaling that causes inflammation. So like for psoriasis, you want to reduce the cytokines that cause keratinocyte differentiation and increase proliferation. So for example, in the first one, the JAK1 and 3 are very selective inhibitors. And we're going to talk about two of those JAK inhibitors that are in the new pool of treatment modalities. The TYK2 now, the TYK2 is another group we talk about. Those are, again, the tyrosine kinase inhibitors. The one that just got improved was just in the last 2 weeks was deucrictibant. And I'm going to give you the fancy names because I know it's always hard when I'm just talking about the generics. You want to match it with the drug that's out there. So this one is going to be, it's just been called, came out, as I said, it's called SOTYKU, so TYK2. I love the name because it's a TYK2 inhibitor. And so TYK2 is the name of it. I love the name. I think they spend hours trying to figure out these names sometimes.
So that's the name we're going to hear it by, Nancy. That's the commercial.
Yeah. So when I talk about it later, I'm going to talk about more specifically later how it works and show you pictures, okay? And then the selective JAK1 inhibitors, already you're aware of abrocitinib, which is Synvinquil, which is FDA approved now for atopic dermatitis. That just came out in the last couple of months. And upadacitinib, which is Rinvoq. Okay, and you all know that as the new oral tablet too. We're going to talk about each of these specifically in just a few minutes. But I kind of wanted to show you where they are on the spectrum of treatment. Now, there's the stats are actually better for psoriasis in my experience. The JAK1, 2, and 3s seem to be the better, especially the JAK1 are much more selective for atopic dermatitis. So that's something that I'll be kind of addressing as I talk about each drug. And I'm going to talk about each drug, the topical and the systemic, and where they're used, okay? And many of you know baricitinib is a non-selective JAK inhibitor. It is now FDA approved for alopecia areata. I think you've already had a talk on that, and you will hear a lot about it. And it's a wonderful, exciting new product for alopecia. So again, many of these topically, and we're going to talk about ruxolitinib, which is Opzelura. We're going to talk about that in a few minutes. So that's a topical that's been FDA approved for atopic and vitiligo, by the way. So we'll go to each one specifically and talk about some studies with them.
So
And
Nancy,
again,
question,
yes.
I might have been answering a question and didn't hear it. So what's the stat versus the JAK?
Okay, so STAT is it's a whole different kind of pathway but they're all kind of classed together. But the STAT again is the signal transmitted inducer for transcription. So it works differently, but it works kind of with a JAK. So a lot of the JAKs are in a class kind of by themselves at the receptor site, but the stats work more intracellular with ATP. But that's a whole kind of, they're all kind of a classification together, but the stats are a little separated out because I find that they work a little bit differently. So, but again, they're called the non-selective JAK inhibitors. The selective will be either JAK1, 2, or 3, as I mentioned, but sometimes they'll combine like a JAK1 and JAK2. So you can see how that what they affect. So the TYK2 and the stats are all kind of a group that are affected. Now, there's not many stats out yet, but except for baricitinib. We'll talk about that in a minute, but they work by affecting, again, the ATP and the inducer cell in the cells, within the cell, to change gene transcription and reduce cytokine inflammation that affects all these different diseases. So again, the IL-13s are very important for atopic. The IL-13, IL-27s are often used in atopic as well. We're seeing these used more for vitiligo. So you can see the interleukins they affect, and they block the cytokine inflammation of these groups. And we have a new one that just came out last couple of weeks too, Spizologib, which I don't actually know the generic name yet, but I think it's just getting FDA approved for, you may have heard, for acute blistering pustular psoriasis. There's only 9 cases reported of using it, but it's been found to be very effective. And it's actually an infusion that you give one time and then wait 3 months. I just heard about that last week, and I'm researching that too to find out more. So I haven't really talked about that yet in my slide set, but that is another exciting new addition. Okay, that's an IL-36. So that's not even on the screen, by the way. So that's more of a biologic, which I didn't add yet to my slide deck. Okay, next slide. So again, you can see that the different JAK inhibitors are important for atopic. We're going to talk about the topical and the oral. We're going to talk about the oral ones for alopecia areata, and we're going to talk about which ones are approved and which ones aren't now, vitiligo. And I'm going to kind of go through them by topical and oral, by the product and how they're used. There are a lot of these that aren't FDA approved yet. I'll mention really soon. Nail psoriasis, we found that this one, we'll talk about this one in a minute, we're very excited about it in nail psoriasis. Also, this one hasn't been FDA approved, so I don't have a name for it, but dolutegravir is being studied right now in chronic severe hand psoriasis, dermatitis, so moderate to severe hand psoriasis. Again, dermatomyositis, you can see the oral products, the graft versus host, baricitinib, we'll talk about that, has actually been used for that, not only for alopecia areata. Lichen planopilaris, there's some of these being studied right now, and also for discoid lupus. These haven't been approved for some of these. These diagnoses have no approval yet of these bottom 2, but will be in the near future, I have a feeling. Okay, next. I hope I'm not overwhelming you. Please don't hesitate. At the end, we'll have time for questions. But this one, this has just been approved by the FDA, Opzelura, which is the ruxolitinib 1.5 cream. It is approved for atopic dermatitis and for non-segmental vitiligo. It is actually approved for 12 and older, and it's also for eczema, approved for mild to moderate dermatitis. So it comes in a 60-gram tube, and it's applied twice daily. They usually recommend, because of the size of the tube, 60 grams does not go a long way. And that's why, again, it's for non-segmental vitiligo, but you don't want to treat more than 20% BSA because you just won't have enough product. It's very, not price effective to treat more than 20%. And they recommended up to 8 weeks. Of course, you can treat on, then stop and then maintain with other products or go back on it. But the studies were, of course, done up to 8 weeks, but obviously many of us are going to use it much longer to get the best effect. There are also ongoing studies in graft versus host, as I mentioned, hidradenitis suppurativa, and necrobiosis lipoidica, and LE, discoid LE. So this is very exciting because it's been going to probably get approval and many other uses. But right now, we're so excited because I've used it already in atopics, and I've been giving samples and starting to write it for my vitiligos. But I want to mention that my vitiligos and in the studies, the ones that do best are not only getting Opzelura, but are also on narrow band. They will get the quickest and best results, to be honest with you. Okay, next.
And everyone, you can go to the chat box and ask questions. We'll answer all questions in between.
Yes, later, because I'm sure you're going to have a lot of questions. Yeah. So I don't blame you, because this is a whole new field. So again, the true AD1 and AD2 tests with the cream Opzelura showed that patients, and this is showing examples of the head and neck, and also a chest where you have a lot of involvement. And these are just some of the study patients. So the patients that achieved, they want to get like a PASI total target dose of at least 50 to 75% improvement. Usually it's 50%. We're happy with those. 50% on the 0.75 and 53%. So the improvement was seen best, of course, on the 1.5 cream. And obviously that's why it's improved. And so as you can see, these are the, as you know, all phase 3 trials have a 1 and 2 study. They'll have 2 arms at 2 different sites, but there are a lot of patients in these studies, 1,250 patients, as you see. And what, not only did they have at least 50%, approximately 54 and 51% improvement with the creams, but also they had significant itch reduction versus the vehicle within as quickly as 12 hours of the first application. So that's very exciting. The topical is very useful for itch. And as you can see, this patient with the head and neck is baseline, but even as quickly as week 4, that is a very, very good improvement. You still see some residual redness, but definitely this, I would say, is more than 50% improvement in my book. And then just showing you a chest also at week 4. This is the close-up. Actually, this is an anticubital fossa, I'm sorry. And just showing you the improvement on another patient in the study. Next. And I thank Derek and Pat for their IT help. They've been both wonderful, by the way. Vitiligo, again, is where it's also approved, the 1.5% cream. And, you know, the reps are being great. They're bringing samples, by the way. So don't be afraid to ask. They've been wonderful at helping me get my patients started with samples so that you can, patient sampling to make sure they get started, and then we can get it, approved by their insurance. So again, just showing you the cream and vitiligo. So, one of the most challenging can be often the hands, which are challenging though. So you're going to see the extremities, especially in the truncal areas, may not work as quickly, but there is going to be improvement. The facial does respond beautifully with the cream in the TRUE study. So they did a phase 3 TRUE study with 300 patients using, again, the 1.5 cream, and 30% achieved greater than 75% improvement at 24 weeks. And this is showing you without phototherapy, as you can see. So these are some different patients. And then you can see at week 20, and you're seeing that repigmentation perifollicular. We know that means they're going to repigment. This is with phototherapy. Notice the combination of the topical with phototherapy, we're seeing quicker response. So hopefully you have or can have narrow band, that will speed your repigmentation with phototherapy. So it's nice to see the studies. If you don't, It still steadily will work, so don't be discouraged. But with narrowband, I'm finding the combination with narrowband and the cream are working much better. I need to start taking more pictures of my patients to share with you, but these are great pictures from the study groups. Next slide, please. And then showing you an alopecia areata. Now, I think many of you know the SALT, which is the severity of alopecia areata. It's called the SALT scores. So when I know I didn't realize I didn't put in the slide on how you do SALT scores. So you have 42%, the top of your scalp is 40%. The back of your scalp is 42%, and each side is 18%. So that'll add up to 100%. So in other words, if I saw 20% improvement of the top of the scalp, which is 40% but I only saw 50% improvement, then I would add 20%. Let's say I saw only 10% improvement or of the sides, each side being 18, then you would add 1.8% or and then 1.8% if you only had 50% improvement. And the back of the scalp, let's say you had 50% improvement again of 42%. So then you add 50% of the 42%. Does that make sense? That would be 21. So your SALT score is the combination of what percentage of each area, and you add them up. The total max would be 100, obviously, but most times you're going to get about 50% improvement. But many patients will be happy, but we're happy when they reach that 75 to 100. So the percent change is how they do the studies based on the percentage in the scalp. So you want to reach a SALT 50% improvement at least, and even thrilled if you get a 90% improvement. Now, I want you to share with you that alopecia of the eyebrows is one of the most challenging to treat. So that can make it very challenging, and you're looking at your SALT scores. But in this original open label in 19, they showed that the SALT 50 was achieved in 50% of the patients at week 24. And that's not a lot of patients, but we've got, other larger studies going on. Next. So I hope I'm making it clear, but don't be afraid to ask. I know it's a little tricky understanding all these scorings now because they're different than like EASI score and PASI score, but that we have for psoriasis and eczema, but still it makes sense because you want at least 50 and even up to 90% improvement. So again, the reduced plaque thickness, size, erythema, and scaling when you see it in plaque psoriasis. One thing I found that the JAKs topically aren't remarkable, but can be useful in psoriasis. They're not approved for psoriasis yet, but we do see some patients with improvement. And these patients did have an improvement of their PASI scores. So with the topical, so you can see that, of course, using it BID basically works better than with the when you're using the 0.5% once a day. Obviously, you're going to get better results. So, and this is showing you again a patient. They're comparing it to calcipotriene and also to beta-methazone dipronate. So you can see that actually sometimes the JAKs aren't as remarkable, but I think they're going to be a nice consideration. But for plaque psoriasis right now, we do not have that approval. It's better for atopic in my experience and vitiligo. So just to mention, though, there are studies in progress with it and probably with different percentages. But at least you can see in the treatment groups, 53% improved compared to, but the vehicle group did well too. It's not bad to have a 32% improvement. But this is just showing you at 28 days before and after. And that's again with 1.5. Okay, next slide. And just also talking about the Jakavi, which is the oral I'm sorry, relax. I practice this really well. Now I'm tripping over them, but reluxatinib. Anyway, it's a non-selective JAK inhibitor, but it has selectivity for JAK1 and 2. So this one is being used more for myelofibrosis, for graft versus host patients who may be steroid refractory. And it is approved, but we don't use it a lot in derm unless you see graft versus host, which I kind of see at times. Because of Loma Linda has a very active, of course, transplant program, but we do a lot of narrow band with those patients too. But what I think will be interesting is looking at these studies in solid organ transplant patients who have advanced squamous cell. I think that study looks very interesting and exciting. So this is a JAK1 and 2 selective inhibitor, and that's the oral form. Next. And just showing you, okay, and the Jakavi, which is oral form, which is studies are going on in alopecia areata, not FDA approved yet, but just showing some great examples. These are moderate to severe atopic. You can see they have a lot of involvement. Basically, the patient, they had 12 patients. They used the 20 milligrams BID for 3 to 6 months, and they had 9 of the patients of the 12 had greater than 50% growth. And 92% reduced their total SALT score. And as you can see, many of these have high SALT scores. So you can see this will have 100% SALT score, and you want to reduce that full, this looks like more like an alopecia universalis patient, I believe, in this one. But anyway, some of the 9 patients had at least 95% regrowth in 6 months. So you can see again, the patients. But the thing is to think about, remember, if you take them off the drug, after 12 weeks off the drug, 3 of the 9 had disease relapse. That's what's always kind of frustrating, because, are we going to have them on long-term low dose treatment? Is it a wise, safe treatment? But patients are so happy, as you can see, when you see that kind of response. So there's multiple patients. They're showing all 12 patients in the study, actually.
So Nancy,
yes.
Do we know how did the the 9, 10, and 12, how did the universalis patients do? Do we know who relapsed? Was it them or some of the others?
Yeah, it tends to be more of the universalis patients that relapse, of course, unfortunately. And especially if you have eyebrow, those are more hard to grow. The eyebrow, when they have eyebrow involvement, those are the more severe too. And those are usually, of course, the universalis patients that will have a complete eyebrow loss. And those seem to be hard. And also 6 of the 9 after 12 weeks off had increased shedding. So again, you're going to have gradual loss. So, and again, unfortunately, 3 of those 9 had complete relapse. So
how long can, do we know how long was the safety duration? How long can they use it? Or
those are in this process right now. Those studies are presently going way out. They're going to probably go out to 1 and up to 5 years eventually. But right now, I know they're in the process of doing the 1-year studies, the extended trials. That's a great question. And I think we'll have so much better data, obviously. So that's what's disappointing. When you stop, will they relapse, and that's always the hard part. Okay, next slide. Next slide, please. Thank you. Again, the oral form used in vitiligo, and the pigment regression occurred again after discontinuing it in about 12 weeks. So once again, they showed those that started the drug and their improvement. Again, 85% at week 12 scalp regrowth compared to 63% at baseline. And then 51 with facial pigmentation had week 20 improvement, and the dosing was 20 milligrams twice a week for 20 weeks. This is just a case study in a 35-year-old male. So he definitely has improvement. But again, if we stop, will we have regression? Also, hair regrowth was maintained as well in this patient. So we're treating both vitiligo and hair loss. So, okay, next. That's only one example though, anecdotal. Now you know another one that's been FDA approved, and many of you are aware of Simbinquo, which is the oral JAK1 inhibitor. It is approved a few months ago. I think it's been about 3 to 4 months now. And maybe I'm wrong, but it has been on the market. Many of you may have seen our reps. It is a Pfizer drug. The dosing is 100 to or 200 milligrams a day. Actually, in patients who are on drugs that CYP450 inhibitors, unfortunately, or if they have renal poor metabolism because of renal dysfunction, they recommend that they only be on the 50 a day, and for especially patients over 65. Moderate renal impairment, not responding to the 50 milligram dosing, you can go up to 100. Prurigo nodularis is the ongoing studies, and chronic pruritus, long-term safety and efficacy. And as many of you know, actually, just to throw in, not to compare, but dupilumab, as you know, was just FDA approved for prurigo nodularis. I think you're all probably aware of that just last week or two. So dupilumab is now FDA approved for prurigo nodularis as well, which is an IL-4 13. So it's a biologic, not a JAK. But I had to throw that in so I didn't forget to remind you of that. Comparison of oral, again, and subcutaneous dupilumab was done in their studies. So that's what's going on right now for future studies to compare the drugs. So of course, our gold standard right now is dupilumab because it's been FDA approved for a while now. So the JAKs are probably are trying to do comparison studies as well for long-term use. So right now it's only approved 18 or greater. I know they do have studies for 12 or greater, so that are probably going to be released in the near future. And probably I would expect it will be FDA approved for 12 and older. Okay, next slide. And this is just showing you the Simbinqua patients, easy scores, then 75 improvement is your ideal. And, you know, you're going to see patients in there. They did the J1 and 2 with monotherapy in their phase 3 trials. And you can see that the 20 milligram is superior to the 100 milligram. Easy 75 was about 60% and about 42% on the average easy 75 with 100. And the placebo as compared. Also peak itching, if there were improvement, they had a, you know, as many of you know, mild pruritus on these peak pruritus scales are either 0, no itch at all, up to 3 is mild, 4 to 7 is moderate, and 8 to 10 is severe itch. So you want to see them improve from like 8 down to 4. Or from mild, severe down to either moderate or mild by 4 points. So they had about 60% improvement with the 20 milligrams and about 40 with that. So 80%, actually the 12-week easy scores were 82% on the 200 milligram, 60% on the 100 milligrams as compared to placebo. So this is a great study, and it is a phase 2 trial, and phase 3 trials are ongoing, but it is FDA approved already for eczema. Next slide, please. And just showing you again the PASI 75s with plaque psoriasis. As you can see, plaque is not as remarkable. As I mentioned, these drugs, the JAKs, I think are much better for eczema. And just comparing in psoriasis in a phase 2 study that was done in about 59 patients, again, not remarkable, but it's acceptable. And at 4 weeks, 60% at twice daily is very acceptable. So PASI score improvement. So not yet approved for psoriasis though. Next slide. And again, we talked about the selective, this is a selective JAK1 inhibitor. I nickname it, but it's Rinvoq. It was approved also, as you all know, in the recent months for 12 and older with moderate to severe atopic. It comes in a 50 milligrams and a 30 milligram, and they have phase 3 extensions again, approved in children. They've got, they're going to probably have it in younger children and looking at the safety and tolerability in the pediatric group. Also, studies going on in non-segmental vitiligo. And what's interesting is these JAK1s are being also studied in hidradenitis. So, okay, next slide. And it's just showing you some good examples again of atopic with Rinvoq, FDA approved already, so it is available to you. And it is, this is an AbbVie product. And your reps again can bring you samples. They are bringing them to the field. So it will be nice to do that, to be able to get samples and start your more severe patients that may be failing other products, especially if you have long-term steroid patients. This is where I think you'll do it. If they don't want to go on an injectable like Dupi, or if they fail Dupi, dupilumab, this is a good alternative for atopic or the JAKs systemically. They are in pill form. Again, you can see at the different dosaging, 74% of patients had a easy score improvement at 30 milligrams. So again, they often have pruritus improving very rapidly with the JAKs, as quickly as, like we mentioned, another one was within 12 hours. This one was within a day of their first dose. So that's really an exciting part. And then there's comparative studies ongoing. And as you can see, again, the improvement of this patient, definitely you can see at week 16 study patient.
So Nancy,
yes.
So could you, I know you have a lot of experience with Rinvoq. So could you just kind of take us, like, when do you begin it? You know?
Yes, can I go to that at the very end? Do you mind?
Yes.
Yeah. So let me move. I better move through these more quickly too. I realize.
Oh, you're doing great.
Yeah, no, because I want to, at the end, I want to tell you about the blood work we recommend.
Oh, okay.
They recommend and all that.
These pictures are great.
Aren't they great? Yeah. Okay, next slide. So I know this is a lot of information, and I'm going to talk about, of course, oral baricitinib or Illuminant. As many of you know, that is now FDA approved for a JAK inhibitor 1 and 2 for severe alopecia areata. Great studies with it. They recommend a 4 milligram per day, and it's also can be used for moderate to severe atopic dermatitis. It's again, they're doing studies actually with pyoderma gangrenosum, very severe, more severe vitiligo. I'm very excited that they're doing a lot of lichen planus studies and with these drugs, the JAKs, and of course now they're looking at children with atopic. Next slide. So again, it's FDA approved already, and it's the first and only pill that was FDA approved for severe alopecia areata. So the dosing began at 2 once daily. Then they recommend increasing to 4 if they have not improved in basically 6 weeks or 12 weeks. Then you can keep going up. But once you get the hair growth you want, like at about 6 months, after 4 milligrams, then they recommend reducing to 2 milligrams and to continue treatment. Because once again, unfortunately, and these are after 36 weeks, these studies, and this is Dr. King, who was involved in the original study, showing you some great results. It is impressive. And they had the BRAVE 1 and 2 studies. So 38% of people had a less than 20 SALT score. In other words, they come from 100, maybe 100% involvement down to less than 20, definitely in that patient. And they did the study in 1,200 patients, but 38% of patients and 35 in the other arm of the BRAVE study did the best in the 4 milligrams. So it is approved at 4 milligrams. They say to start the 2 milligrams, maybe for the first month to see tolerance. And then after that, increase to 4 milligrams. I am in the process of putting a patient on that. I have to admit, I should be having more experience with it already, but I'm not taking a lot of new patients. So I'm not getting all the new interesting alopecia areatas I used to get. So, but I know my associate, Dr. Janine Luke, is involved in hair. And so she's seeing some of these in our practice as well. Okay, new, next slide. So new and exciting. Again, just showing you that patients improved with their loss of sleep in atopic dermatitis. The oral form is not approved yet for atopic. They used a 4 milligram dose in the BREEZE 1 and 2 studies for atopic. As you can see, we're going back and forth between different diseases, but with the same drug. They definitely have improved sleep loss and pruritus. So again, not approved for atopic, but I think in the near future. They also did a study, and actually people, if they can continue like topical steroids or definitely ceramides, these patients obviously will do better when you use combo treatment. So I'm not saying never use your steroids again, but you can actually reduce the need for topical steroids. Next slide. Not approved yet for atopic and not approved yet for plaque psoriasis. Again, I find you're seeing we're using a higher dose of oral baricitinib or Luminet. 54% with a 10 milligram at week 12, got a PASI 75, which is not bad, but you know, we're getting higher with our biologics, to be honest with you. Next slide. But you know, we're looking at it for all diseases. And there's the topical correctin. It's used in Japan for atopic. It's not approved. It's not even, no major studies. I think there's ongoing studies in the United States with the different cream vehicles for atopic in all ages, but not approved yet. This is a pan-JAK, they call it, and has an effect in the JAK 1, 2, 3, and 4. So next slide. And then the oral, again, there's an oral form. Well, there's a topical for atopic. Most of the studies that are with this drug are in Japan, not approved in the United States yet. But you can see again, improvement can be about, the 3% ointment was about 72%. So I think when it gets to the United States, we'll be getting that approved and eventually also. Next, it's called Correctin. Also for hand dermatitis, this is where I'm really excited when I see the literature for chronic hand eczema. So Correctin, not approved yet in the United States, but a lot of studies are ongoing in the United States right now, as you can see. And it's first was approved, it's being used a lot in Japan already. Next. And topical, again, to tofacitinib. Many of you are aware of this. It's a JAK 1 and 3. It's the 2% cream. There's no current ongoing studies, but they found that it could decrease the IL-4 and 31 block that causes it. And I think there's studies ongoing right now, and we'll see if it's approved in the United States. Next slide. I just see there's so many classes of this, aren't there? There's a topical that they've used in the EASY score, not approved yet in the United States, but about 82% reduction in the EASY score. So this is just showing you. Don't have any pictures of this at present. Next slide. So I'm kind of going through the ones that are not approved right now. The 2% ointment, again, was being used in studies to reduce alopecia areata. And they didn't have a lot of patients. This group was 10 patients. As you can see, though, 4 months later, 6 months later with a topical ointment, that's still very exciting, isn't it? And then this was only 4 patients, but showing you a patient with a 93% solve improvement from, that's really is a good example. Next slide. And that's with the topical. Also in vitiligo, they found that patients had best response in type 4 through 6 with this drug, with the topical and vitiligo. And again, showing you 11 patients who did a combination, though. They do best when you can, again, like I mentioned before, do narrow band at least 3 times a week and use the cream daily to do BID. So their vitiligo improvement was 70% in this study patient, non-segmental. Okay, next slide. Again, plaque psoriasis, not remarkable data compared to your biologics, but I mean, it's consideration. So again, I'm finding that JAKs are much better in atopic and vitiligo than they are in psoriasis, but maybe certain percentages and vehicles will see it approved in the future. Next slide. And then the oral, many of you know the oral form of tofacitinib is Xeljanz. This was one of the first ones FDA approved for rheumatoid arthritis. It's a JAK 1 and 3 inhibitor. It's approved for psoriatic arthritis, by the way, but not for psoriasis, again, to remind you. But it's a 5 milligram twice daily. It's also approved for children greater than 2 for their juvenile rheumatoid polyarticular. Also, it's approved for ulcerative colitis, 10 milligrams BID for 8 weeks, and then they dropped to 5. So again, it's expanding its use. The FDA declined a request to get it approved for skin. It's good for psoriatic arthritis, but doesn't seem to be quite as good for skin, as I've mentioned kind of over and over now. And again, other studies are in lupus, GA, and systemic sclerosis. Next slide. And again, atopic dermatitis, they had an improvement of 66%. Hasn't been approved for atopic yet, but 5 milligrams once or twice daily plus topical study, open label study, but only 6 patients. But you can definitely see the improvement. And this was at 12 weeks. Next. And again, showing you Xeljanz and some atopic, not approved yet. I'm sorry, alopecia, not approved yet again, but there's multiple studies ongoing in its use, but can be effective, it appears. Next slide. And vitiligo again, the Xeljanz, repigmentation. They use the 5 milligram every other day. And one study in 15 and 17, they did a retrospective. And they only found the best results were, again, with patients who were getting narrowband plus the oral form. Next.
Nancy,
Not approved yet.
Is the oral form approved for anything yet here in the States?
Xeljanz, it's approved for psoriatic arthritis.
That's it. Okay.
Yeah, mainly, and rheumatoid arthritis, I'm sorry. Yeah. So and in children, it's approved. Do you want to go back to that? Can you go back like 3 slides? I'm sorry. Sorry about that. I think I gave the Xeljanz one more. There you go. For psoriatic arthritis, rheumatoid, the FDA approval. For juvenile and for ulcerative colitis, those are the approvals for Xeljanz. Thank you. And then we'll go forward 4 more slides. Okay, and plaque psoriasis, not real remarkable. But for psoriatic arthritis, yes, approved. Next.
Nancy, there's a question.
Oh, sure. I'm not looking, sorry.
No. Can you repeat the scalp area? Hi, Beverly. Can you?
Oh, for the SALT scores?
Yeah.
So when you're looking at SALT scores, 18% of the parietal area. So 18. The top is 40% of your scalp and the back is 42%. So when you add all those up, it's 36 plus, let's see, I hope I'm saying it right. 36 plus 42 plus 40, it should be equal 100%. So your SALT score is based on, let's say you 18%, you have 18% loss here, 18% loss here, that's 36. And then you have only 50% loss here. So that would be 20% of 40% of your scalp. Does that make sense? So that would be 20 plus 36 is 56. And if you have no loss in back, so you'd only have a 50%, 56% SALT score if you are losing everything on the sides and half on the top, for example. Does that make sense? So when you have improvement, you base it on what percentage of this 40% has improved, what percent of the 18 has improved, and what percent of the 46% in the back of the scalp has improved. Does that make sense? I know it's very confusing, but that's called the SALT score.
Thank you.
So, yeah, scalp area response. I hope that makes sense now. I should have had a picture of that. And I apologize. I didn't get that in. Now, deucravacitinib was just approved. Like this is the TYK2 I was telling you about called SOTYKTU. It's SOTYKTU. It's called SOTYKTU. I love the name. It means TYK2, but it's spelled TU at the end, and it starts with SO. This was just approved like September 10th. And the slide was put in just before it was going to be approved, and it was. So Bristol Myers makes this. It's it's been shown to really be quite effective, I think, starting to be effective in nail psoriasis, but it's approved for moderate to severe plaque psoriasis. It is a pill. And there's studies with its long-term use, and it's also looking at lupus in this. So this just got approved. Next slide. So this is the TYK inhibitor. A lot of people think maybe the TYK are a little safer. I don't know yet. I think we'll see long-term studies that'll help us. but it was compared to a course, Otezla, apremilast, and placebo. So the studies were in, and apremilast isn't a remarkable clearer, but this was superior to apremilast. But it's just an alternative to consider, and it's an oral form of medication. Next slide. And basically, it is FDA approved. The milligrams is 6 milligrams, by the way, once a day. They saw improvement. Their studies were PASI 75 improvement. I have the data right here. I just pulled it up. Their endpoints were a 75% improvement at week 16 was 58%, and the PSO1 and the PSO2 was 53%. So it's not as remarkable as the biologics, but yet it's going to be, I think, a great alternative. So that just got FDA approved like 2 weeks ago. So exciting, huh? Next is a TYK2, JAK1. I don't have any experience with this. This is in studies, not FDA approved yet, but another group. So you can see we're using kind of overlap inhibitors that work in different pathways. Next slide. And we're doing pretty well for time, but I want to get to the end too, so plaque psoriasis, again, the oral form, I no experience with it, but they're in studies and not FDA approved. I think they're going to be doing phase 3 shortly. These are only the 2A trials, but you can see the 30 milligram, they had 86% improvement in plaque psoriasis for PASI 75 patients in at week 12. So, and 90, not bad, 50% improvement, PASI 90 improvement at week 12. But it was 212 patients, which isn't a bad group of patients. Okay, next slide. And alopecia, they're using that same drug. Improvement was 51% from baseline. Again, they had a 4-week and a 20-week, 4-week induction and a 20-week. So it was a 24-week study. So kind of interesting. Another one that's probably going to be coming soon. Next slide. I'm trying not to overwhelm you too much. This is a JAK3 by itself. Again, ongoing studies. It is being studied for alopecia areata. Next, I don't have a name for it yet. As you can see, they're only numbers right now. So alopecia areata, again, another phase 2 study. A lot of phase 2 studies, meaning they're not yet even in phase 3 or soon to be in phase 3, which is when those studies are when you're going to get them FDA approved, as you all know. But these are the basic phase 2 are, of course, to see if they're going to be some improvement. And yeah, 33% improvement for baseline and alopecia isn't bad at all. So, and then they have looking at the Allegro study, they were looking at adverse effects. We're going to talk about those in a minute. Next. And then this is another JAK1. This is actually, again, in studies. And they were finding that this might be used in combination with the BRAF1 mutant melanoma and other solid tumor patients with other inhibitors. So this is maybe a future melanoma treatment. Next. I don't have any pictures on these either because these aren't FDA approved and still only in phase 2 trials. This is one, just to mention, a pan-JAK again. It's called Simraf. It's approved in Japan for rheumatoid arthritis. There's ongoing studies again that are being done. PAP is doing a study in plaque psoriasis, a phase 2A. So the improvement is not remarkable, but it can be achieved. So PASI 75, seen at 16 weeks, not bad with the pill, but you have to use the higher milligrams, obviously. Next. And now, what are the common side effects? Great question that we had from Wendy before. Their common side effects are going to be similar to what you see with a lot of the biologics: nasopharyngitis, diarrhea, ear infections. Sometimes an eosinophil count will be increased, urticaria-like rash, folliculitis, tonsillitis, and rhinorrhea. Another thing that's been seen with Rinvoq and Cemminco, as you may be aware, is an acne-like eruption or a folliculitis. And that usually comes up within the first month or first 2 to 4 weeks. And it does get better over time, but it can be annoying to patients. So it is treated right like regular acne. One of my patients who had it basically had to be treated with, we used just topical Clinda, like I did BPO wash, and over time it resolves it by itself, but I helped it speed away a little faster. And I should have a picture of that one again, but it's a classic, papular pustular acne that can occur. So that's one of the concerns that some patients will have, especially if you're treating younger patients like teenagers or young people in their 20s or 30s that are already acne prone. JAKs can maybe trigger a little more acne breakout. The more severe side effects, of course, with the oral JAKs are going to be your viral infections. They can have bacterial infections like urinary tract infections, fatigue. Again, the acne is mentioned again here. The gastroenteritis, bacterial, fungal, viral infections are much more common, but also just to remind you, they are more common in patients with atopic dermatitis. So remember that. And also thrombocytopenia has been reported, upper abdominal pain. So next slide. Now, what do you do to work these patients up? Next slide, please. So basically, I think the other thing I don't want to negate is that in studies with Rinvoq and Simbinquil, there are reports of increased cardiovascular. They were all in patients. There was one death in one of the groups, but it was a patient who was over 65, who was on the drug, actually having COVID, was hospitalized for COVID. He had multiple comorbidities and a greater than 65-year-old passed. The other patients did not. Now, there have been slight increases in malignancies, but that will be seen in long-term studies. So basically the malignancies that we're seeing, like with Rinvoq and with Simbinquil, were mainly skin cancers, which are treatable, not life-threatening, but they each had like an adenocarcinoma, one of the colon and one of the groups. One had breast cancer, of course, but that's going to be normal for age. So most of them I don't feel are blamed on drug, but we do have to mention those, of course. So you're going to want to be careful with your patient who has a history of, breast cancer. I'm not going to, put a patient on breast cancer without getting an okay from their oncologist. I'm not going to probably put the drug on a patient. Also, the other side effect, as you all know, is DVTs have been reported with the JAKs. Now, that was based on Xeljanz, which was approved for rheumatoid arthritis. And those patients usually have multiple comorbidities. They're older patients, often with diabetes, with metabolic syndrome, and multiple other medical issues. They're usually on multiple drugs like NSAIDs and so on. So you have to keep that in mind, that our younger group, I feel much safer. I will feel much more comfortable using it. Our younger, healthier patients, and I will be with somebody my age group over 65. I'm blessed not to have comorbidities like that, but many of my patients at that age do. So they do recommend, and it can increase lipids. So, heart attacks and cardiovascular strokes are reported more in older patient groups, again, with these, but there have been no real deaths that I saw in their original studies. So of course there's ongoing data. So the companies like Rinvoq and Simbinquil recommend a complete blood count. They recommend a CMP baseline, because you can have a drop in your neutrophils, you can have a drop in eosinophils. So you don't want to put patients on, you can have a drop in your platelet count. So you can have thrombocytopenia reported rarely. So I recommend a baseline, as almost I always do with biologics, a blood count, a comprehensive metabolic. You want to make sure their renal function is good, or you reduce the dose. They don't recommend a lipid profile sometimes till at least 12 weeks. But I recommend baseline and 12 weeks. You check those lipids, because otherwise you may want to stop treatment. And I would not want to put a pregnant woman on it. So get your beta HCG. So personal recommendations also are to do baseline and I repeat all the labs at 12 weeks. And then also I would recommend a Quant Gold, and the company I believe does. They don't recommend it, but I would do your hepatitis screening for B and C and HIV. just like I do for the biologics, because I don't want to put a patient on a drug that can increase side effects. So I basically do this for the biologics, except for the lipids. And the lipids is something that JAK inhibitors you need to do. So I hope I've answered, did that answer all the questions? And then I probably would do them every 3 to 6 months thereafter, but definitely baseline CBC, chem profile, baseline quant gold, hepatitis B, C, HIV, comprehensive metabolic, lipids, beta HCG in women. Now, again, Wendy had a great question. Who do you want to put on this? Again, be careful of comorbidities. Your older patient who's diabetic, who's had a history of BVT, you're not going to put them on a drug. I wouldn't. I'm being very conservative, but I wouldn't advise it. Now, I had a good question one time in one of my talks. What if I have a young woman who has a family history of who's on birth control, has a history of DVTs, is on birth control, and has a family history of maybe cardiac or DVTs? I would be cautious about that young woman, even though she might be only in her 30s. For eczema, I would be cautious probably with her history of DVTs in the family and being also placed on a birth control, which can, possibly increase her chances of DVTs. But I think in general, most of your patients, as long as you do baseline blood work, I often work together with a primary care. I don't think you have to really worry too much about these drugs, but you do want to monitor them, especially lipids. So I hope that's helpful. And I hope I answered the questions you have, Wendy. I know the problem with this is they all have that class effect. So they warn you, be careful of DVTs, cardiovascular, and stroke possibilities. Those are things they recommend, and malignancies that you be cautious of. And I think part of it is because that class effect came from Xeljanz and those difficult rheumatoid arthritis patients on multiple drugs, maybe on multiple anti-inflammatories, and also usually a group of patients who have a lot of comorbidities like, again, metabolic syndrome, diabetes, high blood pressure, and other issues health-wise.
So Nancy, I guess we want a little insight into like your thinking.
Mhm.
You've got a 32-year-old on birth control. She's got, antecubital
Yes. And I
disease.
think my last slide was just references, wasn't it? Just to make sure. I think, did I
Yeah,
have?
just references.
Yeah, okay, we're good. Yeah, I want to make sure I
Yeah.
completed that for you. Yeah, good question, Wendy. So
But
you have a
like,
30-some-year-old.
she's a new patient. Are you
Yes.
going to start with, topicals? Are you going straight
Yes, yes,
jacks? I mean, how do you decide who's
yeah.
topical, who's jack, and that kind of decision making? And like, what percentage of body area would you
Yeah.
use? That kind of thing.
Yeah, I think if you're going to use the topical jacks, by the way, unfortunately, it depends on your insurance company. And unfortunately, at Loma Linda, we do have a lot of HMOs. So we have to jump through a lot more hoops sometimes. And you do it with the private patients with a wonderful PPO insurance. But for the topicals, you probably will have to fail topical steroids, which most of your patients will, at least 1 or 2 classes. Some of the companies may make you say you have to fail the calcineurin inhibitors, so Protopic or Alagel. Now, I haven't run into that yet, but it may happen. But as long as you prove that they failed, and the topical, you don't want to use it if they have more than 20% body surface area. The topicals, you're going to want to go to the orals, especially for moderate to severe atopic. And so basically, those, I would only use the topicals if they're less than 20%, actually probably ideally less than 10% body surface area. And you have to have failed steroids and possibly the calcineurin inhibitors, which are also hard to get sometimes. And they have a class effect too. But I've been able to give samples, and if the patient's responding, then I'll tell the company when I'm writing the script, I'll keep it in my notes, they've responded. and you try to say what percentage they responded and what period of time. Like in a month, I see a 50% improvement. Document that because they want to see your notes, and you can usually get approval. Now, if they failed dupilumab, if they're on long-term systemic steroids with atopic dermatitis greater than 20% of their body, then I think you should consider oral. So you're going to consider either a biologic probably, or you're going to consider a JAK inhibitor. And I think the nice thing is the JAK is a pill that's easy to take. However, you got to think about, hey, I've got an acne patient in my 20s with bad atopic and acne. Could the JAK make their acne temporary a little worse? Yes, it could. So you have to kind of keep that in mind, but not that bad. It's treatable. As I said, it usually gets better over time. So the acne isn't severe, but it's just a frustrating side effect that you might have with a patient that's younger. So, but the JAKs, I think, are just a good alternative. And I don't have massive experience yet. So I'm with you in that we're all kind of on a learning curve with them. They've just recently got approved, but they're an exciting group of drugs. So,
Thank you. Cynthia, hi, Cynthia has a question.
oh, sure. Thank you.
How often would you do the pregnancy test?
The pregnancy test, that's a great question. Definitely baseline. And I think I would just ask the patient to advise them not to become pregnant. And I probably would only do the pregnancy test. You're not required like you are with isotretinoin, which is, a teratogenic drug. So I would just do a baseline and then just talk to them about the importance of not getting pregnant on the drug, or to advise you if they're going to plan pregnancy. Sort of like tretinoin, right? You just, you don't want to do pregnancy tests all the time, but you do recommend that they, stop the drug if they're becoming pregnant or trying to become pregnant.
Right.
That's a great question, Cynthia. That's what I would do, but some people might be more conservative, some people less conservative.
Nancy, that was an amazing summary of the JAK inhibitors.
Oh, I know, and I'm sorry I kind
You
of
are the
overwhelmed you, but at
woman.
least I have great pictures for you all, which I hope are helpful. I know we're on this learning curve with the JAKs, and that's why I learned so much doing this as well. And I know I'm just in the infancy of learning to use it better and more, and I'm planning to, but
We're
yeah.
just so grateful to have you, just teaching us all of this. So,
Oh, I'm so glad to be doing it
yeah.
for you.
Are you ready for immunobiologics? Are you?
Yes, I am. Oh, yes.
Do we need to feed you or something?
No, I'm good. I'll take
You're good? Okay.
I'll
All
take
right.
a sip of my Diet Coke.
Well,
I'm good. Thank you, though.
good. Okay.
Now, this is kind of a talk I started to give, but last year for Wendy, but we had a problem bringing it up. But it's still a great base, generational talk. And I'm not going to talk as much about the safety, but I'm going to kind of share with you what patients you should use what for, and what group of classes to avoid. That's really what we want. We want to know there's so many new biologics out. It's so exciting. And again, I think one of our rotators who from internal medicine, she was actually rotated with us applying for derm, was Anna Chen, for helping me with this talk as well. A couple of years she actually rotated 2 years ago. Okay, next.
I'm going to ask you a question.
Sure.
Why did you put safety during the COVID-19 pandemic?
Because a lot of patients were questioning this. Actually, I did a year ago, and when a lot of people were scared about using the biologics, we're talking about, should you stop a biological during the COVID? And no, we now know that the safety is actually good. They were actually showing the cardiovascular protective effects of all these drugs now are good. And unless they do recommend still, if you have active severe disease, you probably should hold your biologic when you're running a fever. That's even known already. But I kind of addressed that question because a lot of people were scared. And also I started seeing a lot of flares of psoriasis. I actually hospitalized a number of patients after they got their vaccination, but that was early on, like in the 2020, when we were really hadn't have our we were just starting to get our vaccine, or early 2021. And a lot of people were just frightened because they were seeing some side effects with the vaccines. So, and flaring of psoriasis. So, okay, next slide. So good question. We'll move on. Next slide, please. And again, let's move on. We're going to talk about quickly their mechanism of action. Do you want me to do that much, or just jump right into the classifications, Doc? You just tell me. I'll try to move quickly. So let's move to the next slide. Yeah, this is a good start. This is where you're going to, this is the classifications of the main drugs that we're going to use in our office, not infusion, except for infliximab, which, as you know, is Remicade. So the TNF alphas all came out about 20 years ago. Many of you know Enbrel, next infliximab is Remicade. Adalimumab is Humira. Certolizumab is Cimzia. And then golimumab is Simponi, and it's actually not approved for skin. It's only approved for psoriatic arthritis. So I don't use that for skin. Okay, the interleukin. Next was after that shortly. Oops, I'm sorry. Can you go back? The next classification, not the next slide, sorry, is the IL-12/23s. You know, ustekinumab is Stelara. And then shortly after that, in a few years, the IL-17s came out. So secukinumab is Cosentyx, izokizumab is Taltz, and brodalumab is Siliq. So those are all that class. A new one any day now, I'm very excited about, because it's the new one, bimekizumab. Many of you have heard about it. It got kind of held up for approval because of the manufacturer in Europe and having the people go over with the FDA to get it approved. So I think it's going to be out early next year, but it's going to be a game changer. It's going to be an IL-17AF. So it's going to be a very good inhibitor. And then last, the IL-23s, as you all know, guselkumab is Tremfya, tildrakizumab is Aluma, which it has to be given in the office, and risankizumab is, you know, all know as Skyrizi. So I will try to do all those by their given name now, so it makes it easier. Is that okay with everyone? Okay, next slide.
Please.
So basically, they all work by reducing inflammation that promote the differentiation of T17, T22, and Th1 cells. So TNF alpha regulates the ability of the dendritic cells to activate T cells, which causes keratinocyte proliferation, inflammation. And as you all know, the triggers for psoriasis are going to be trauma, infections that cause these dendritic cells to become more inflammatory cells that increase cytokines that cause inflammation. So basically, you know, those classifications are how they regulate. Now, the IL-23 released by these dendritic cells drives this IL-17A production. So again, they cause recruitment of other inflammatory cells. They cause stimulation of the keratinocytes, and it leads to this inflammatory loop that causes mature inflammatory thick plaque. So I said that quickly, didn't I? But at least to remind you how they work. Next slide. And again, just showing you where they all work real quickly. You know, the IL-23s and then ustekinumab, which is IL-12/23, work by reducing that regulatory IL-17 cell. The Cosentyx, the IL-17s all work in this area by reducing, again, inflammation. So they block that T regulatory 17-1 and H1 cells to becoming inflammatory. But if they get here, you know, all these inflammation is going to really increase recruitment of other inflammatory cells. So you get this chronic inflammatory cycle. The TNF alphas block here, the IL-12 and 23, ustekinumab blocks all across here. So again, this is the innate immune, and this is the adaptive immune response. So next. So psoriasis, we're going to talk about the TNF alphas again. when they incept CEPT, they're a soluble TNF receptor binding to TNF alpha and beta. So Enbrel is unique in that regard. All the others say MAB on the end. That means they're a monoclonal antibody and they're purified. This is Remicade is a chimeric and they bind to TNF alpha. Again, Humira is fully humanized. Cimzia is a pegylated. And one thing nice about the pegylated is it can be used in pregnancy because it doesn't go through the placenta, interestingly. So that's where Cimzia is a really good drug for women who might be of childbearing age. And then, as I mentioned, golimumab is only really approved for psoriatic arthritis, so I don't use it for the skin. Next slide. And this is just kind of showing you its general use. So again, I want to remind you, Enbrel is approved for all of these arthritis plus plaque psoriasis. It is also approved for juvenile idiopathic greater than 2 years of age and plaque psoriasis greater than 4 years of age. It is well tolerated in the geriatric, but none of these are FDA approved in pregnancy and lactation. However, I have several patients who have been on Enbrel who became pregnant. I worked with and I don't recommend it, but one of my patients was when I used to work in Northern California. I worked in Red Bluff for a number of years because my ex-husband had moved into Chico area. So I had a lady who had 3 of her 6 children on Enbrel and scared the heck out of me every time she became pregnant and didn't tell me. But I actually talked to her OBGYN who actually okayed it and watched her carefully, and she had all 3 normal children. But again, there's not a lot of studies in pregnancy. You have to be aware that there have been reports of risk of congenital defects, which are rare. They have often higher risk of preterm births and reduced weight. Denmark studies, similar studies showed not a lot of patients, but something that's what concerned me. But I was so blessed that this patient had 3 that have been were normal children as far as we know through, and as they developed, I have not heard of any issues. Again, Remicade is an infusion. It is probably best if you have multiple autoimmune diseases. We used to use this more, but for when they had severe ulcerative colitis, when they had maybe plaque psoriasis and psoriatic arthritis, it would be really nice to use for that. It is approved for greater than 6 years in Crohn's and ulcerative colitis. It is, again, this is the only one of all these that's not injectable. It is an infusion, as you probably all know. So again, be cautious in pregnancies. Because of it's a very effective drug. It hasn't really been studied in 65 or over, but really none of these have. So I had an 80-year-old on a biologic years ago because she was so severe. She did great on Humira, but at that time, that was one of the only few drugs, Enbrel and Humira, that were available. Humira, again, is also FDA approved, as you all know, was the first and only approved for hidradenitis of the suppurativa, the biologics. And also it's approved for non-infectious uveitis, if you didn't know about that. It is approval that maybe you wouldn't know as much unless you work with ophthalmology. It is approved for greater than 12 years for hidradenitis. It's approved for juvenile rheumatoid greater than 2 years of age. Unfortunately, we've never got the psoriasis approval for greater than 18, but it is approved for much younger in Europe. And I know you could get it if you had requested it years ago, but now we have a lot of other new drugs that are approved down younger. Now, the one thing about Enbrel I really like, it's a good drug. However, you probably remember one of the big drawbacks to Enbrel is that you have to give it twice weekly for, like for the first 3 months, and then you drop down to once weekly. So it's a frequent injection versus, like Humira, you do a loading dose and then it's, twice monthly. So every other week. So that was one thing that we favored about Humira, and it had a little higher PASI scores. But the TNF alphas are kind of becoming our old guns because their PASI scores were like 69 and 71% at 16 weeks. Now we've got the like we have the interleukin 17s, and now our IL-23s that have PASI 90 and 100s now. So we're all kind of moving away from this older group and using the more effective and faster acting newer group with also better safety. Another big problem I found with Enbrel and Humira were if a patient had to go off for some reason, like they had a severe infection, they were off, or they sometimes surgeons wanted to take them off in the old days before they were going to have surgery, like a knee surgery. I always found that because of their neutralizing antibodies, it was hard to recapture their effectiveness. So that is another disadvantage of the anti-TNFs. Next slide. So the newer group of the like Cimzia, as I said, this is actually safer in pregnancy. It hasn't been approved in pediatric nor in pregnancy, but it does not cross the placenta. So this is another, Cimzia is another good one to consider. And if you were having a young woman that you wanted to be safe with and worried about pregnancy, but I always tell pregnant women they shouldn't be on these drugs. And as I said, I don't use this except for psoriatic arthritis, and our room people use that. So next slide. And this is just showing you the effectiveness of etanercept. It actually was a patient who was erythrodermic. They're not actually FDA approved for erythroderma, but again, showing you the baseline patient and then 3 months after treatment. You can see the erythrodermic psoriasis with definite improvement, although she does have hypopigmentation where the psoriasis plaques were afterwards. So she came from more erythrodermic, and you can see more plaque-like in those areas like the knees, elbows, the classic areas, her low back or abdomen had thicker plaques, those hypopigmented. Next slide. And this is just showing you again, Humira. And that was a game changer when it came out, as all of you know, the TNF alphas, because we had nothing other than methotrexate, cyclosporin A, light therapy, tar and light, and TARs and topicals. But now you see the improvement. And again, with adalimumab after 3 months and then after 8 months. So you have definite PASI clearing. Most of these drugs, their effectiveness doesn't occur till 12 to 16 weeks. You'll see the change like here. You're seeing quite the change at 12 weeks. Usually with Humira, their PASI 75 is about 72% at 16 weeks or 12 weeks. And then they improve over time. And that's a good clearing. Next photo. Now the IL-12/23, again, and the I-23 inhibitors are very effective, and they are very useful against neoplasms. The only problem, again, with the IL-20, the good thing about the IL-23s, by the way, is that they are also effective in Crohn's and ulcerative colitis. So if you have patients with that, and which is a drawback to the IL-17s, because they can worsen not only Candida, but they can also worsen Crohn's or ulcerative colitis or unmask. Some people are concerned they can unmask irritable bowel disease. So, but this group is quite safe, but I found that with Stelara was good, but a lot of my patients that you give a loading dose once, 1 month later, and then every 12 weeks, a lot of my patients seem to flare at about 8 weeks. And so I felt like I wish that I could give them the drug more frequently, every 8 weeks instead of 12 weeks. But the good thing about Stelara is also by weight. So if they're under 100 kilos, they were getting 4 to 5 milligrams. If they're over 100 kilos, they were getting the 9. So that one is based on weight. Okay, and then these IL-23s, which are the new group, as we talked about, drive and maintains the differentiation of T helper cells, T17 and T22. And so they reduce that promotion of hyperproliferation in psoriasis. Next. And again, they think that IL-23 may be more important to the pathogenesis of psoriasis. So that's why this new group of antagonists are Tremfya, Luma, and Skyrizi are so popular and have had such high PASI scores. And by the way, Skyrizi and Tremfya are approved for psoriatic arthritis, and reminding you that 30 to 40% of your patients with plaque psoriasis will probably at some time in their life have psoriatic arthritis. So when I see our patients, I always think about and ask about their joints every time I see them. And if they're really severe, I often will include my rheumatologist. I'm kind of blessed because I have a good relationship with their rheum department. And so we often work very closely together and deciding what drug to put them on. But I want to remind you that Skyrizi also just not long ago got approved for Crohn's disease as well. So, which is very interesting. Okay, next slide. And this is a Stelara again. It's approved for kids greater than 6 years of age. One of my first patients with really bad psoriasis that was age 16, and actually she was age 14. I put her on Enbrel when it was approved for younger age. And then she developed over time, she has developed ulcerative colitis. So then her GI people switched her to ustekinumab, and it's really improved not only her ulcerative colitis, but her plaque psoriasis. So that is a patient that you might want to consider Stelara. And I like its safety as well. Again, not approved in pregnancy or breastfeeding, but you know, we all have to make the benefits and the risk have to be combined. Next slide. And then the IL-23s, again, as I said, I haven't updated because now it's approved for, this is approved, Skyrizi is now approved for psoriatic arthritis. And just like, I think a month or two ago, it just got approved again for Crohn's. So this is an infusion, or it has to be given in the office. And I have an issue with Illuma because we have really a tight issue about our lawyers in our office. So for patients to come in, have drug delivered to us, or have the patient bring in their own drug, quotes, we don't want to take a chance of tampering. So I have a tough attorneys at Loma Linda, which I don't blame them. So they are not really encouraging us to give it in office. So that's why I've kind of not used Illuma as much as I would like to, but I use a great deal of Tremfya and Skyrizi. And now it's also good. You don't have to fail. In the good old days, you know, we used to have to fail methotrexate or cyclosporin A before we could use the TNF alphas. Then with the TNF alphas, you had to fail before you could use like the class 17As and so on. So it's very frustrating, I think, to be using drugs, having to have that. Now we don't. These are two go-to drugs, and their safety is really good. They don't even require blood work except baseline CBC chem in this group of drugs. However, I get baseline again. I still get Hep B and C. I still get quant golds, and you should get quant golds and all the biologics baseline. And then I get the quant golds yearly. But I always—
Can I ask a question?
Sure.
Sorry to interrupt. This is amazing.
Yes.
It's such a great talk. I needed this.
Thank you.
What about LFTs and Skyrizi? I know there was
I do get baseline CBC, chem profile, and all of these.
But I mean, are you worried about transaminases or transaminitis in these drugs, or
Not
is that
really, not in the IL-23s, not like we did with the TNF alphas. Yeah.
okay?
Yeah, good question.
Thank you.
And I just love the safety, and I love how fast this works. Like these drugs work so fast. You give like with Skyrizi and both of them on Tremfya, you give baseline, you give that 1 month, And then Tremfya you give every 8 weeks. With Skyrizi, you give every 12 weeks. I mean, within a month, a lot of my patients have 50 to 60% improvement already. And they work so remarkably fast. That's what I love about the 23s. And now that they've been approved for psoriatic arthritis, that makes them my major to go, to be honest with you, because of their safety. Also, they're durable. You use them, their studies 3 and 5 years, they're very durable. They get that 90 to 100% clearing and they keep it. And if you take them off drugs, they recapture beautifully. That's the other good thing about this drug. So these are my real to-go-tos now because of their safety, because of their efficacy, their durability. So to be honest with you.
The Skyrizi and Tremfya.
And Illuma, if you give in the office, is great too. But as I said, Tremfya and Skyrizi kind of are my to-go-to. They have been not FDA approved under the age of 18. So, but you probably could get it because their safety is there. They haven't been established, but I'm sure like in pediatric groups or under 18, I know they're probably going to get that approval in the future, to be honest with you. But in the meantime, you might want to think about staying with your old standbys. So the IL-17s are approved down to age 12, like Taltz. So you might want to consider that as well. Okay, and let's see, next slide. Oops, sorry, I was trying to move it. My apologies, but this shows you nail psoriasis at baseline and after 4th injection of Stelara. So all of them are doing studies in scalp and nail psoriasis. So that's remarkable, isn't it? So to see that improvement. Next slide. And this is just showing you another example of a patient with Tremfya, and just showing you week 0 PASI pretty high of 15. By week 28 have dropped to 0.9, and by week 52 they're essentially clear, and they maintain that clearness. The patient B below, PASI of 80 body surface area. They use body surface area in the clinic a lot of times. I don't use PASI as much except in studies, to be honest with you. So body surface area 87%. Notice by week 28 down to 7%, and they'll usually maintain this PASI 1% at week 52. So really good response, isn't it? Very nice to see, and patients are so happy. And yesterday I saw one of my long-term patients who had kind of been lost to follow-up for a little while, and I realized now that we had about in June, I put him on, he was a young gentleman. I put him on back on Humira because he'd done so well with it. Actually, no, I'm sorry, Skyrizi, not Humira. Originally he was on Humira. He seemed to fail that. So we placed him on Skyrizi. He actually took a dose in June, but got COVID. So the pharmacy never refilled it, unfortunately, and he never asked for his second dose. So, but he already was 6 months out, well, June, July, August, September, October. So he's about 5 months, 4 to 5 months out from his one dose. And he still had 50% improvement, a PASI 50% improvement. So I know he'll get better now that he'll go back and be regular with his drug. But he was depressed because of his psoriasis. He said, people at work, I said, well, you get on this drug and stay on this drug, you're going to do well. But think about these patients, send them to the information on the National Psoriasis Foundation. I sent him to his primary I sent a message to his primary, please help this patient with counseling. These patients' quality of life, as you can see, can be so severe. He said people were teasing him at work because of his psoriasis, and he worked in a warehouse. And now he's so much better. He says, I feel like a different person, but yet he still has that depression. So think about your patients, really take good care of them, because think about not only their physical, their skin, their joints, but think about their emotional and quality of life. Next picture. And then again, the IL-17s are great, as I said. So Cosentyx, Siliq, and Taltz. These are the IL-17s. Let's go to those next. And again, Cosentyx, Siliq. This is Cosentyx is approved basically in pediatric use for moderate to severe. Their phase 3, I think they haven't gotten it down to the young age yet, but I know it will be. And they, Siliq, they haven't really done a lot of studies with it. It's approved for plaque psoriasis, but it works fast. The only problem with Siliq is, unfortunately, I got kind of black boxed with a depression warning. And I think it's because this was studied later on. You're going to get all your more difficult failed Humira, failed Enbrel, failed, Stelara, failed multiple therapies, failed methotrexate or whatever. They get in those studies, and there are already patients who have failed multiple drugs and have a lot of depression. So unfortunately with Siliq, you do have to go through a training. It's not major, but you have to get certification to order this drug because of depression. So I don't use it as much because of that issue, because I have a residency and I have to have comfort with my residents using it, and they would have to eventually get the certification, but it is a great drug. But I tend to use Cosentyx. Notice it has multiple approvals, including ankylosing spondylitis. Again, geriatric, we're in the process of getting those approved. And pregnancy, again, not approved. Next slide. Taltz is approved for 6 or older now. So it does have the lower approval. So again, the IL-17 group, the last 2 plus this one, remember, increased mucocutaneous candidiasis. I have problem with women getting more yeast infections on it. So you're going to want to maybe use fluconazole to treat them as well. And also, again, it can unmask. It should not be used in patients with ulcerative colitis or Crohn's, okay? Because it can make it more severe. Or if they've had a history, it could reactivate it if it's been controlled. So be cautious of that. That's the only drawback, I think, in the IL-17s that worry me. And then again, Taltz is approved for also ankylosing spondylitis, spondyloarthritis, plaque psoriasis, and psoriatic arthritis. So, but it is also for younger groups as well. Next. And just showing you a patient again with Cosentyx. And this patient, and I have several patients with this. There is a study they've done with Cosentyx and hidradenitis suppurativa, and I think we're going to see that approved also in the near future. But I have a patient with horrible psoriasis and hidradenitis, like this patient. This is a study patient, but I had a patient on Humira, and his psoriasis just cleared beautifully. His arthritis is well controlled, and and of course, with Humira, as you know, for hidradenitis, is double the dose of psoriasis. His hidradenitis suppurativa has taken a while, but it's really improved. But can you imagine having hidradenitis and psoriasis and psoriatic arthritis? Bless their hearts. But this is just showing it with Cosentyx in their studies, and I think it's going to get FDA approved and probably also in the future for hidradenitis, but just showing you the improvement of patients. And this is a patient with both diseases. So next slide. And again, moving on, safety. Next slide. Thank you. I don't know if you want to go into COVID, but let's keep moving. I'm going to have you move into the next few slides. These are just cohort studies that were done right in the middle of COVID. I'm not going to address this till the very end slide. So I want to give you time for question and answer. So keep going. Sorry. Thank you for being so patient with me. Next slide. And I think there's a last slide and 2 more. And this is the recommendations of the American Academy of Dermatology and Rheumatology for during COVID, by the way. And they said to continue all your immunosuppressive therapy. There was a concern at one time that you should stop them if they had COVID. Yes, I'd probably hold if they had high fever, their injection, but you can go back on it as long as their fever is gone, but I'd probably wait 2 weeks. They recommend again that you restart systemic suppression after complete recovery based on the CDC guidance, and that when systemic immunosuppression is considered, it should be recommended with the risk versus benefits. At the beginning of COVID, I had like 3 patients that were referred by a local dermatologist that were hospitalized after actually COVID vaccinations for either erythrodermic psoriasis or they became pustular psoriasis. So we controlled them with cyclosporin A, all 3 of them, but then they became, then I was able to switch them to a biologic. So after that, so I think all 3 of the patients, to be honest with you, I put them on IL-23, either Tremfya or Skyrizi, and they've done beautifully. The American College of Rheumatology actually said again to delay or discontinue the IL-6. They use a lot of IL-6s, none of ours are, and JAK inhibitors with known either SARS exposure or confirmed COVID-19. For uncomplicated infections that are in the ambulatory setting, they allow reinitiation with 7 to 14 days. So they were a little more liberal about getting them back on biologics. I always waited at minimum of 2 weeks, and the patient is asymptomatic with a positive PCR, reinitiation treatment may be considered 10 to 17 days after. So I think that's all gotten a little bit more relaxed again too. Next slide. And I wanted to share this, and I hope this is from Dr. Liebald, bless his heart, from Fall Clinical last year. This is an amazing little quick reference sheet. If you don't have that, you can go online with Fall Clinical conference and get a copy of this, or if you want, you can copy it now. But I love it because it gives the ages it's approved for. First of all, it gives you the brand name, the generic name of all the class of the really active drugs right now in biologics, and again, it shows you what class they're in and their dose, and then loading dose and their maintenance dose. So it's a wonderful quick reference. I do want to mention at the bottom, I should have talked more about Dupixent. Many of you know I didn't talk about the Dupixent like I should have, but it is well approved for atopic dermatitis. It is approved now for peds. Actually, now it's down to 3 months, believe it or not. Also, you may not, I don't have experience, but I do respect this drug. It's an IL-16 Adbry. You may have seen it. It's another injectable, trachelitinib. It's approved for 18 or older. It's another very good, I'm sorry, it's an IL-13. It's a very good drug. So it shows the IL classifications they are, and it's just a wonderful quick reference. So I hope that helps. So that might be a nice one to get. You can go online to Fall Clinical if you haven't, or, you know, I went on to Fall Clinical dermatology conference line, and you can get a copy of this, or go under with Dr. This is Dr. Mark Liebald, who, as you know, is an incredible psoriasis guru, biologic guru, who put this together. And I think it's so beautiful. I have it in my office. My residents are always checking it as we're seeing patients. So, okay. Well, thank you wonderfully for your, oh my gosh, I told Wendy, can I do 2 hours? Do you think I really could do 2 hours? Sure enough, I did. So Wendy, let's, you know, are you ready for questions and answers? And I haven't been looking at my chat, sorry. So.
No, I knew you had a lot to share. Thank you so much.
Yeah, and I hope this was helpful. And I think little tip sheets like that are just so easy and helpful.
Yeah, this is great. Can open
Do you
up
want me to go over lab for most of them? Again, I always get a baseline CBC chem profile. Before I start any biologic, I do Quant Gold. And I didn't even talk about, I should have talked about oral Tesla, by the way, but I didn't include that in this.
I was going to ask you about
yeah.
Otezla.
Otezla, apremilast, actually is a great drug too, and I should have included it in here because I was talking more about the injectable biologics. So apremilast, Otezla is a great oral therapy. It is safe. You don't have to do TB testing with it. It is given 30 milligrams BID. I do baseline CBC chem profile with it. But you don't have to worry so much about the hepatitis with the biologics. So with the biologics, I always do Hep B or C because, example, the TNF alphas can reactivate Hep B. So always do with the biologics. I always do HIV, a quick reagent, HIV, Quant Gold, CBC, chem profile. But with Otezla, it's an oral. It doesn't need TB testing. I just do a baseline CBC and chem profile. If they have decreased renal function, you might want to decrease the dose to 30 a day, but they have a special formula that you can figure that out if they have a, or I always, if I have a couple patients who are their nephrologists, I've gotten an okay to continue them on 30 milligrams. The biggest problem with it can be is diarrhea, nausea. One side effect, which I think is not a side effect, is about 10% of patients can lose weight on it. It's probably because of the GI or upset or diarrhea. I shouldn't say that, but it isn't serious. Usually it's not a serious issue. It has been now approved for mild to moderate to severe psoriasis. Originally, it was only moderate to severe, and now they got the indication. So a lot of primary care are using it for mild psoriasis. And to remind you, mild psoriasis is 3% of the body surface area or less. Moderate is 3 to 10%, and severe is greater than 10% body surface area, just to remind you. So with Otezla, you know, I rarely do lab. I'll do baseline. I'd like to do it every 6 months. You know, I'm really sorry to say a lot of my primary care through COVID, patients were able to get into the primary care or weren't making their normal appointments. So in a way, when you have them on these drugs, you kind of become sometimes their primary care temporarily. But I don't like to be the full primary care, but I'm probably a little bit more conservative about doing lab because of that. So Otezla is 30 milligrams BID. They have a starter dose, which starts at a low dose. It starts at as 5 milligrams a day. So by day 6, you're at full dose. So it starts at like 5, then the next day 10, then 15, then 20, and so on. So that supposedly reduces their diarrhea effect. So the company is great. Amgen now owns Otezla, by the way. Used to be Celgene. They bought out Celgene. So your Amgen rep now will be your Otezla rep as well. But it's a great oral therapy. It doesn't have as high of PASI scores, but if they use it steadily, patients do by 6 months, we'll see at least 50 to 60% improvement versus the biologics now do have a higher PASI score, of course, of 90 to 100 clearing rate. So, but it's a good alternative and I use it, and I've actually become using it more in patients who may find their biologic isn't quite up to what they want. And the rheumatologists are big at putting people on methotrexate along with a biologic. I don't like to do that. I like to avoid methotrexate now. It's a good drug in its day, but now we have such better drugs, safer, no liver issues. I often combine Otezla maybe with a biologic that might be failing. So it's interesting, but that is off label and that is not FDA approved, but I think we're going to see more studies with combination drugs.
Nancy, how about a Vitama? How do you like that?
Oh yes, I just started using it. That's a good question. This is a topical apremilast, right?
Yeah, I've been
PD
very pleased, and I've actually been getting away with using it in
Yes.
intertriginous psoriasis.
Yes, that's a
as
great
well,
area.
like
So
on the skin behind.
intertriginous,
Yeah.
I agree totally with that. It's very safe. I've been using it a lot more. It's called Vitama. It's a PDE4 inhibitor topically. Yes, thank you for reminding me. I don't want to forget that. So I just started using it. I just got samples. So it's great. Yes.
Yeah.
I gave it to a patient who, again, had inframammary psoriasis, just wasn't responding to any therapy. She does have a home light box, but you know, she just can't get
Mhm.
treatment well under her breast, and Vitama really helped her. So good comment. Thank you so much. Any other questions or comments? So I was just wondering if I know I've totally forgotten to mention something. I did mention for acute pustular psoriasis, there's an IL-36 that just came out about 2 weeks ago. It is an infusion. They only have 9 cases, but I think of severe pustular psoriasis diffusely. We've seen them, not commonly. I have seen a couple of those after vaccination. So it is something that you might see, but I haven't any experience with the drug yet. And it is an IL-36. So, gosh, there's so many new ones coming out and so many topicals. So I hope I've helped you, guide you a little bit. But I said, I'm in my infancy with the JAKs, but I am learning fast. I'm finding where trying to place them, I know is a question for you. But I think they're wonderful alternatives. It's nice to have such a big, you know, tool, so many tools in our toolboxes right now for psoriasis and eczema. So
Really exploded.
This was awesome.
Yeah.
Telling you.
oh, thank you.
You
Oh,
amazing.
thank you so much.
Wasn't it amazing?
I know it's not as fun as cosmetics sometimes, but no, it's really important. You know, and I love, as you know, I think many of you know, the reason I went into psoriasis because I trained at Henry Ford, and I had one of my young patients I met at age 16 was from a very wealthy family in Detroit. You know, Detroit's the Motor City. And she tried to commit suicide. And she made me realize how important it is to treat these autoimmune diseases. So that's why when I came back, I was invited back. I was going to practice with my dad in Michigan. I grew up in Michigan, and my dad was a dermatologist, and I grew up in Battle Creek, Michigan. I was going to join my dad in practice, but Loma Linda didn't have a derm department really yet. So I was honored to be invited back to Loma Linda, where I went to medical school to build the practice. And that's why it became so important to me to treat psoriasis patients, because of my patients in my residency who had really quality of life issues. And, you know, we can just be so much help. And just to put in a plug for National Psoriasis Foundation, they're so wonderful. Try to get your patients help through them as well. They can help. They have wonderful assistant programs, and they have wonderful things. And next year I'm going to ask Wendy to let me talk next spring on I have an updated alternative therapy on herbals. I gave that one a few years ago, but I have updated one on use of herbals and nutrition and psoriasis. So I hopefully I'm going to ask Wendy to let me give that talk in at President's Weekend. When we see each other face to face.
For that, and this one though too. I mean,
exciting.
I can repeat this one. It'll probably be updated again. The JAKs especially.
We'll have to do. Are you up for 3, Nancy?
Oh, I probably can. Yeah.
Okay.
Yeah, I might repeat a little bit of all these, but I mean, I'll update them. But
Nancy, I have 2 lupus patients, discoid lupus patients on
who's speaking?
Illumia.
I can't see who's speaking. Who's speaking?
Oh, Eva.
Oh, Eva. Hi, Eva.
Hi.
Yes.
Yeah.
I thought I recognized your voice. Yeah.
They're on Illumia and they're doing really well.
Oh, that's great. Yeah, you're using Illumia in your office, which is great, isn't it?
Yeah, for the discoid lupus. They came to me on them, but I'm also managing, I co-manage them with their rheumatologist, but it's really helped their arthritis.
Yes, yes, that's so exciting, isn't it? Yeah. And I think we're going to see more of the JAK inhibitors being used in the lupus too, with rheum. Because, you know, Xeljanz was the first one JAK to be used and approved was for rheumatoid arthritis. So yeah, great comment. So
all right.
Yes. Oh, thank you.
Well, thanks, everyone.
You've been a wonderful group. It's so wonderful to have you all here. Thank you, Wendy, for inviting me back again.
We love having you.
Yes, we do.
I feel so smart now, huh? You learned so much. I'm ready to take it on. So next month, it's November 8th. We'll see everybody back then. And have a great evening and a great rest of the month.
Yes, thank you all again.
Oh,
And
thank
we
you.
wish you the best. Be safe,
Yeah.
everyone. Be healthy. Okay.
Okay.
Thanks.
Bye.
Thank you, Wendy. Thank your IT people. They're
Oh,
incredible.
yeah, they're amazing.
Thank
Yeah.
you, Pat, Derek.
Chat, Derek.
And your staff, Kathy. Thank you them too. They're wonderful.
They are. Thank